And I'd now like to introduce our next speaker, Yvette Bordelon, who is a member of our board of directors, a neurologist. Yvette?
All right, welcome back. As Richard mentioned, I'm one of the neurologists. I'm also from the West Coast, so there's folks from Colorado. I'm from California, so I'm from UCLA. We're the West Coast contingent, just waking up our time, I think, right? I'm a movement disorder neurologist at UCLA. I did spend some time in Boston before heading out to California and still have some good friends and colleagues working out here as well. I'm very honored to be here today, to be a part of this conference, to be a part of your day, soaking information in, as well as sharing information with everyone here. We really appreciate your participation. Dr. Golby gave a nice overview of PSP and the atypical Parkinsonisms. I'll go over that again in brief, and then talk about some of the other atypical Parkinsonisms more specifically: corticobasal degeneration, or CBD, and multiple system atrophy, MSA. I have a few copies that have been circulated around the tables of these slides, so you don't have to feel like you have to write everything down. If you share them among families and stuff like that, there'll be that information, and if you need more, let the folks in the back know, and we can mail that out. That's no problem. So again, we're talking about variants of Parkinson disease. These are defined as Parkinsonism. Parkinsonism is just a general term for describing stiffness and slowness. And with these atypical Parkinsonian disorders, it's Parkinsonism plus additional features. So they're also called Parkinson plus syndromes. You'll see that out there as well. And again, we'll refer to it as APD, or atypical Parkinson disease. We also mentioned, too, the diagnosis is often delayed or inaccurate. And Janet mentioned that in describing her experience with her husband, and as many of you have experienced over time. But why is that the case? Why does it take so long before we can pin this down and say that this is one of the variants of Parkinson's, PSP, CBD, or MSA? Well, it's because those atypical features, or the signs and symptoms, usually emerge later in the disease. And the disease doesn't happen overnight. It's not like a stroke in the brain that happens where it's a sudden change, sudden neurologic deficit. It's very gradual, even intermittent at the beginning. And so it sometimes takes months, most often years, before those atypical features emerge to the point that a diagnosis can be made. In addition, sometimes it is after experience with certain medications. We try medications that we think will work for Parkinson's, or that will work for other problems or disorders, and they don't work. Or the disease is progressing faster than what we would think for Parkinson's disease or other diagnoses, and that's again when we begin to consider that this is an atypical Parkinson's disease. We're also susceptible because we don't have a specific diagnostic test for Parkinson's disease or for any of the variants of the Parkinsonisms as yet. There isn't a blood test that we can do to confirm diagnosis. It's based on the clinical exam, what we know from what you've experienced over time, and then what we see on the neurologic examination. So that clinical diagnosis remains the gold standard for diagnosing these disorders now. And a definitive diagnosis is only made at the time of autopsy. It's those pathologic changes that define the syndromes. And that is true for almost all of the neurodegenerative disorders. There are a few rare genetic disorders, and Huntington disease is an example where if someone carries that gene mutation, they will definitely develop the disease, so we can diagnose that pre-mortem. But all others, the definitive diagnosis is made at autopsy. So again, we talked a lot about PSP, or Dr. Golby spoke a lot about PSP. So that's Parkinson's disease plus core features, eye movement abnormalities, as well as balance problems. I'll speak about corticobasal degeneration. This is also referred to as corticobasal syndrome, CBD, CBS. We like to speak in abbreviations. And I'll explain why we have that terminology a little bit as well. That is Parkinsonism plus apraxia. So apraxia is how the brain knows how to perform a certain movement, and you lose the ability to perform that certain movement, how to brush your teeth. It's the act of performing the brushing the teeth that is impaired. In addition to some of the actual movement problems, dystonia or cramping or involuntary contractions of the muscles that characterize this particular disorder. And then multiple system atrophy, MSA, that's Parkinsonism plus dysautonomia. So autonomic nervous system controls your blood pressure, so there's drops in blood pressure with changes in position that will lead to fainting spells, urinary incontinence, and other features that go along with MSA. And we'll talk about these second two here. I'll mention again other Parkinsonisms, because these are things that are evaluated when you go in to see your internist and your neurologist. This is what we also look for to make sure these things aren't present. Some of them are treated differently, particularly the one at the bottom, normal pressure hydrocephalus, as Dr. Golby mentioned. That's something that would involve a surgical procedure to treat if possible. And again, vascular Parkinsonism, drug-induced, we look at the medications and the medication history to see if that might be contributing to some of the movement problems that you've been having or that a person has been having over time. Now, one of the other ways we classify this, not just by the exam, and I'll go through some of these other characteristic features for these atypical Parkinson's syndromes, is by the pathology. Again, tau being a protein normally found in the brain, but in certain diseases, it's getting tangled. It's abnormally folding and causing some of the disruption and the cell loss and the symptoms. So that's PSP, CBD, and the frontotemporal dementias, probably others, including Alzheimer's disease. And then synucleinopathies. I mentioned these two because these are the two that I'll be talking about, with CBD being a tauopathy and MSA classically being a synucleinopathy. So synuclein, another normal brain protein that is accumulating abnormally, misfolding in the brain and leading to some of the problems that you see with these disorders. Those synucleinopathies also include Parkinson's disease itself, as well as DLB or dementia with Lewy body disease. With these abnormalities, the reason that we have different syndromes, even though it's a common protein, is based on location within the brain. So this is an MRI taken through the brain in a sagittal section, so through here, nose at the front, back of the head here. In PSP, we know that there will be characteristic tangles of tau, so this misfolded protein in a couple of core areas, brainstem being one, but also basal ganglia. So these are deep structures within the brain, basal ganglia connecting important loops from the cortex down to the basal ganglia, down to the brainstem, and disruption of all of those important loops here, and the brainstem leading to some of the characteristic Parkinsonism that we see, but also the eye movement abnormalities, some of the gait problems. In CBD, we see the pathology is concentrated in a different area. So that's also the basal ganglia, but parts of the cortex. And it's parts of the cortex that are involved in behavior and certain functions. So that praxis, that ability to initiate a particular maneuver or task is centered in parts of the cortex, the parietal cortex being one area. So we see a high burden of pathology in that area. And with MSA, so where do we see these tangles of alpha-synuclein? We see them also in the basal ganglia, as well as the cerebellum, the part of the brain important for coordination, also in the brainstem. These are some of the core differences. The reality is we see pathology throughout the brain in all of these. But this is what kind of distinguishes the clinical syndrome, what part of the brain is being affected by these abnormal proteins, and how those abnormal proteins, how that cellular dysfunction is causing trouble with the circuits in the brain. We don't know why these tangles form, and we don't know why it's in certain areas of the brain that are more susceptible to these yet. There's a lot of work going on to try to figure that out. If you figure out what those triggers are, why certain areas are susceptible, again, you can target those, keep those functioning in a healthy way for a longer period of time. And again, there's a lot of work trying to figure out what that might be. You also see that among the disorders that we're discussing today, there's a common location, which are the basal ganglia. So these deep nuclei that sit under the cortex and are very important for keeping the cortex connected and keeping circuits functioning. Those circuits include motor circuits, mood circuits, and cognitive circuits. So you might see overlap of all of these symptoms within some of these disorders as well. And the risk factors, too, we talked a little bit about in regard to PSP. The same is true for corticobasal degeneration as well as multiple system atrophy. In all of these disorders, age is the greatest risk factor. And as our population ages, we'll probably see more of these illnesses over time. That is going to be true for Alzheimer's disease, Parkinson's disease, and the atypical syndromes as well. But we likely think it's a complex combination of certain genetic risk factors and susceptibilities, these variants of genes that you have inherited, as well as your lifetime experiences, certain exposures, certain experiences, and other features that have not yet, again, been identified. Studies are ongoing to try to figure out what these factors might be. Similar to PSP, again, with CBD and MSA, we look for some of these common variants. And tau is the explanation or the pathological cause of corticobasal degeneration, and thus when we see either mutations or certain haplotypes, as Dr. Golby mentioned, again, this H1 haplotype, we will see that associated more with corticobasal degeneration. Now in MSA, because it's a different protein accumulating in the brain, its alpha-synuclein is the gene, the protein here. If there happen to be mutations or extra copies of that gene, that can lead to Parkinson's disease or MSA. But interestingly, tau has also been found to be associated with those synucleinopathies as well. So it might not be a pure protein problem. And in fact, if you have one protein misfolding problem, you may be susceptible to having others. So just like Alzheimer's disease, there are two proteins that are misfolding, one in cells, one outside of cells. Within some of these neurodegenerative diseases, we might have multiple proteins misfolding. And drugs that are targeting mechanisms that help to clear proteins are great because it'll clear all of the proteins that are accumulating abnormally, not just the one, as opposed to some of the protein-specific therapies. So there's a lot of crosstalk and then potential benefit for therapies down the line as well within these neurodegenerative disorders. In thinking about CBD and MSA, we know much less about those genetic and environmental factors than PSP currently. There are studies that are going on. Some of the large genetic studies that Dr. Golby mentioned for PSP are going on in MSA. Corticobasal degeneration presents some more challenges, which we'll discuss a little bit. But again, those data are being analyzed, and we'll know a lot more as this explosion in genetic technologies continues. And so we'll be able to learn a lot more in these coming years about some of those genetic variants that might contribute to the risk for CBD and MSA. In addition, as light is shed on these other disorders, so some of the novel gene variants that were found in the genome-wide association study for PSP, you begin to look at other disorders to see if you have a common mechanism there as well. So we learn a lot from other disorders. So let's talk first about corticobasal degeneration, or CBS, corticobasal syndrome. It is one of the most difficult diagnoses to establish among the atypical Parkinson's, and that's because there's a significant amount of overlap and variability of the clinical symptoms within individuals with this diagnosis. And there's also overlap with the pathological contributions to similar clinical syndromes. And again, a definitive diagnosis is only made at autopsy. What has been established over time is that the neuron loss, the degeneration with this disorder, occurs primarily in the cortex, the frontoparietal areas of the cortex that I showed before, and it tends to be very asymmetric. So one side of the body tends to be affected first and much more than the other side of the body during the course of the disease. It's not an absolute. Some people do have bilateral symptoms, but by and large, most people with corticobasal syndrome have very asymmetric disease. That is somewhat similar to Parkinson's disease, idiopathic Parkinson's disease, where it's one side of the body that is affected first and tends to be more affected throughout the course of disease. as opposed to PSP and MSA, which are symmetric Parkinsonisms, so that both sides might be affected about the same time and to the same degree. And the reality is we can sort of make those distinguish among these things, but the reality is I have patients with regular Parkinson disease that have both sides affected, and I have many people with MSA and PSP that have one side that's more affected as well. So these are not absolute contributors to the diagnosis. These are just generalities that we try to help in establishing diagnosis. On the pathology, and I'll show a picture of this in a minute, what they describe what is called ballooned neurons, swollen neurons, again having to deal with these tau aggregates within the cell. And these are termed tufted astrocytes when they are occurring in astrocytes, but tau inclusions are also found in neurons. And this is a photomicrograph taken of sections from someone who had corticobasal degeneration, showing the arrows to some of these ballooned neurons or swollen neurons, as well as the brown staining is staining for the protein tau, showing that tau is aggregating abnormally in both neurons and astrocytes throughout the brain. And also, as a reminder, as Dr. Golby had mentioned, there's a lot of overlap within the clinical syndromes, what different syndromes have been named. And you see all the colored boxes, again, overlapping. And the bottom is where the tau is accumulating, whether or not it's cortex versus brainstem, and how these disruptions in the circuits and in these areas of the brains, in areas of the brain, can cause different clinical syndromes, some being what we can best define as corticobasal degeneration or PSP, and others being some other frontotemporal dementia variants, including variants that are behavioral variants or language problems. And the reality is, too, that we see some of those features in people who look like everything else to be PSP or CBD. So there's overlap among the pathologies and among the clinical syndromes. So this further muddies the waters when we're talking about clinical diagnoses and moving forward with research. But the bottom line is what many people have realized is that underlying all of these different colored boxes is that if you can narrow it down to tau or synuclein or a pathologic problem of protein aggregation, it doesn't matter what you call it as a clinical syndrome if you're going to have treatments that will affect the underlying pathology. So I think we're really moving forward in recognizing that. So if you belong to any of the boxes above, you would be eligible then to take a drug that's going to target tau. So those boxes are kind of melding together, which is a good thing. The diagnostic difficulty with corticobasal degeneration, what they've realized is that we as neurologists are not very good at predicting corticobasal degeneration pre-mortem. And in fact, from a lot of the studies that have been published, those folks that carried a diagnosis of corticobasal degeneration, at the time of autopsy, it was revealed that they were pathologically confirmed CBD in only 23 to 56% of the cases. Other diagnoses that were found included PSP, another tau disorder, but Alzheimer's disease as well, and other frontotemporal lobar degenerations of other proteins in the brain that are also misfolding. And when you go backwards, when you look at the cases in the brain bank, for instance, that have a diagnosis of CBD, as Janet had mentioned with her husband, diagnosed pathologically with corticobasal degeneration, when they work backwards, only 25% of those folks had received that diagnosis prior to the autopsy. So it's inaccurate. How can we improve accuracy? It's better definition of the clinical syndrome and recognition of where the pathology is occurring and how it's affecting the circuits in the brain to better predict where the pathology is going to be in the end and how to treat those disorders in the end. So this is where corticobasal syndrome has come about. So that's sort of the clinical syndrome, sort of encompassing some of these symptoms and overlapping symptoms, whereas corticobasal degeneration we reserve for a more specific pathologic diagnosis. So the diagnosis. In general, we know that it has to be a progressive course, usually asymmetric onset, And there has to be the presence of higher cortical dysfunction. As I mentioned, these abnormally folded proteins are being found in certain parts of the cortex, the frontal and parietal areas. So how do we see this on exam? How does a person experience this? One thing that tends to be classically associated with corticobasal syndrome is an alien limb phenomenon. So the limb assumes a position without actual control. In addition, it can also be interpreted as the limb is not recognized as your own. So it's alien to you, or it's doing things that aren't, you're not voluntarily doing. Many times, because dystonia is a part of this abnormal contraction and turning of muscles, the limb will do things, most often grab the other hand, sometimes be brought up in a flexed position, sometimes grab the neck. So it will do things or assume postures without voluntary control. That can happen in the leg as well. So alien limb phenomenon is evidence of this higher cortical dysfunction. And apraxia, again, I gave the example of brushing teeth. It could be any particular movement or task. It is more difficult to execute that task. Somewhat because of the motor problem and the slowness of movement, the dystonia and the rigidity coming out, but more related to that cortex not working well and not telling that limb what to do. Language and speech impairment. So speech impairment can be common among the atypical Parkinsonisms because of the motor problems. But in certain disorders, and corticobasal syndrome is one of them, you will see some language impairment, an aphasia. So coming out with the wrong words. You can't find the right word, but you actually come out with the wrong word. And there are different variants within this language syndrome as well. Again, this can cross over into PSP as well, going back to those colored blocks and lots of overlapping symptoms. But that is also evidence of some of the higher cortical dysfunction that must be necessary in order to consider corticobasal syndrome as a diagnosis. Dystonia, I mentioned a couple times, it's this abnormal turning or contraction of limbs. It could be neck, sometimes face. It can affect any part of the body. It can be present in Parkinson's disease and the other atypical Parkinsonisms as well, but it tends to be more common in corticobasal syndrome than some of the other Parkinsonian disorders. Myoclonus is another movement problem that is more common in corticobasal syndrome and corticobasal degeneration than in PSP or Parkinson's disease. And this myoclonus just means a quick muscle jerk, a quick muscle movement, contraction of muscle. And many times, again, it'll affect the more affected side in corticobasal syndrome, and sometimes will be little muscle jerks. So multi-mini myoclonus is what we would use that as a term, which in some ways looks like a tremor. Tremor is not a typical feature for these disorders, but some movements can be interpreted as tremor. In addition, an inadequate or absent levodopa response also helps to confirm corticobasal syndrome as a likely diagnosis. Other motor features that go along with corticobasal syndrome include bradykinesia, a term that we use for slowness of movement. It could be in the limbs, could be axial features, gait and walking, also slow. Falls, even though we use that as diagnostic criteria for PSP, we see it in corticobasal syndrome too. Many times it's related to that asymmetric one leg being involved as well, with a lot of dystonic turning, so that affects gait, and then praxis. So you can't brush teeth, but you can't walk because it's that motor program that is difficult to achieve with that limb. So falls can occur and gait problems occur with corticobasal syndrome too. Tremor, I mentioned again, a lot of times it's myoclonus, but we can sometimes see an atypical tremor with these disorders. Eye movement abnormalities, again, classic for PSP, but we can also see it in folks with corticobasal syndrome. Again, this overlapping of clinical symptomatology among all the atypical Parkinsonisms and speech impairment. Some of the other cortical symptoms that can be seen include other cognitive impairment, most often executive type dysfunction. Executive function tends to be higher level processing, multitasking, attention, concentration. And because the frontal lobe is affected more so in corticobasal syndrome, we see that in clinically as well. We see it in PSP because those circuits are disrupted. So it's not, again, specific to CBS, but can be seen within that syndrome. and also behavioral changes, again, because of disruption of frontal lobe function and disconnection or malfunctioning with those subcortical areas, the basal ganglia, we can see certain behaviors emerge. Those branch over into then the other side of dementias, the frontotemporal dementias, where sometimes there can be very bizarre behaviors and changes in personality that might predate any of the motor symptoms. So again, lots of crosstalk among the symptoms among these disorders. The diagnostic challenges. So it was recognized, of course, that we weren't very good as neurologists at identifying this disorder. And in fact, depending on what specialist you might see, you would get different diagnoses. And we have different impressions about what certain syndromes are. So I am a movement disorder neurologist. I see mostly Parkinson's disease and variants of Parkinson's disease from a movement perspective. So I viewed corticobasal syndrome and corticobasal degeneration as primarily a motor problem. But in folks who might have some early behavioral or cognitive changes, they'll see a memory disorder specialist or behavioral neurologist who then feel that, well, corticobasal syndrome is a cognitive problem. It's not so much of a movement problem. The movement problem happens later. So we have, sort of depending on who you see, you're going to get different impressions from those specialists as well, another challenge. So a group of specialists was convened, and they published their recommendations regarding refining these criteria for diagnosis earlier this year. And what they did is they developed two models for the diagnosis. So one to sort of have a broad definition. So clinically we could capture as best we can most of the cases of corticobasal degeneration, but another set of criteria that was more rigid and a little bit more narrow, recognizing that what we really want to do is move into clinical trials. And in order to get into clinical trials, we want to have more rigid criteria for certain disorders. So they came up with two sets of diagnostic criteria. So the first, the broader definition, the clinical criteria, and this is for possible corticobasal degeneration, remembering that only a definite diagnosis can only be made at the time of autopsy when we see the pathology. So again, progressive disease and gradual onset. It has to have a duration of at least 1 year. Anything shorter, and we're not sure where things are heading. It's not a long enough time to say that this is CBD. And then they opened up this possibility to be not only asymmetric, but perhaps bilateral involvement, again, to capture more people with this syndrome. And then one of any of the following. So the limb stiffness or slowness, which is rigidity or akinesia, the dystonia, myoclonus, as well as apraxia. And so that can be of the face, it can be of a limb, cortical sensory deficit, again, pulling in these different parts of the cortex, or the alien limb phenomenon. They also list other phenotypes. So phenotypes being another clinical syndrome that has been recognized to have corticobasal degeneration on pathology, which includes some of these language variants, as well as forms of PSP. So again, an all-inclusive type diagnosis. The second set of diagnostic criteria, again, for a more narrow definition, also gradual onset and progressive disease, duration of at least 1 year. They're restrictive about the age of onset and about whether or not certain genes might be contributing, because if there's a certain genetic problem, it's not going to fit into what we term as sporadic necessarily. And again, probably doing this, an asymmetric presentation is the difference here in this set of criteria, and then two of the following of the same list of possibilities. So still lots of variability within these criteria, but again, trying to narrow it down and trying to help us identify and diagnose patients with this syndrome and with this variant of Parkinson's disease, this atypical Parkinsonian syndrome, but also guide future clinical trials that are coming down the pipeline to really improve success with those agents. So how does this compare to the other atypical Parkinsonian syndrome that we'll talk about today, is multiple system atrophy? Again, definitive diagnosis made at autopsy, and this is based on also loss of neurons, but in different parts of the brain, slightly different parts. We know the basal ganglia are affected, certain parts of the brainstem, including the pons and substantia nigra, but also parts of the cerebellum, as we mentioned, as I showed you in the MRI, and spinal cord. The pathologic hallmark is something called a glial cytoplasmic inclusion, and what that's been recognized to be is alpha-synuclein. And these aggregates also occur in neurons and astrocytes, and this is another picture of someone who had MSA, and these glial cytoplasmic inclusions. Again, this is protein that's stained for alpha-synuclein and clumps of alpha-synuclein within the cells, both neurons and astrocytes. And Dr. Golby already mentioned that we used to think, oh, it's just a primary neuron problem, but this disorder was always recognized as a glial problem, now recognized to be in the neuron. It's the crosstalk between these two types of cells in the brain that is likely contributing. And there are some diagnostic criteria to help with this clinically, again, a clinically probable diagnosis for MSA, onset usually greater than age 30, and it is also progressive, characterized by autonomic dysfunction. So this is the Parkinson's plus syndrome, that stiffness and slowness plus dysautonomia. And that's identified or defined as either urinary incontinence, erectile dysfunction in males, or a drop in blood pressure measured by the systolic blood pressure by about 30 points 3 minutes after standing. So that orthostatic hypotension, change in position, drop in blood pressure can lead to fainting and a drop in that blood pressure. Also, helping to confirm a clinical diagnosis is poor response to levodopa or an inadequate response to levodopa. And a cerebellar syndrome can be recognized as well. So the gait ataxia, the swaggering gait that Dr. Golby had mentioned, speech involvement as well as incoordination of movements. And in fact, what they've been able to identify are a few different subtypes of MSA. So MSA, even though we think of it as autonomic dysfunction that must be present, there are a few variants of MSA as well. And the other problem is that they were all previously known as another diagnosis. So you'll see lots of diagnoses out there for what we believe is the same underlying problem. MSA-A for autonomic predominance. This was previously known as Shy-Drager. Again, the dysautonomia is the earliest and the most severe feature of that disorder. MSA-P, P for Parkinsonism, previously known as striatal nigral degeneration. Some elements of Parkinsonism more often looks like Parkinson's disease to begin with, and then one that evolves to have some of the other dysautonomia, poor response to levodopa, that then makes you think that this is an atypical Parkinsonism. And MSA-C for cerebellar, previously known as olivopontocerebellar degeneration. Again, more of the ataxia and cerebellar signs and symptoms along with this subtype of MSA. The mean age of onset for MSA is in the 50s. This is different from Parkinson's, PSP, and CBD, where it's a little bit older in the 60s as the mean age of onset. The prevalence is also low, similar to the other atypicals. 3 to 4 per 100,000 is a rough estimate. And again, it's a progressive disease on average over about 10 years with variability within that duration as well. Other clinical features that support the diagnosis of MSA and can be explained by some of the areas that are involved pathologically include stridor, which is noisy breathing. There are certain parts of the brainstem that can regulate vocal cord function. And when you lose that function, you have stridor or noisy breathing. So that can be a feature that goes along with MSA. And often, not often, I've had a few folks that have been referred to me from ENT physicians because they've found vocal cord paralysis, usually unilateral vocal cord paralysis at first, to say, hey, maybe there's something else going on. And turns out that they evolve into a syndrome that looks like MSA. Cardiac arrhythmias are also not uncommon and might be a common feature, again, getting to some of the autonomic problems and other problems that we can see in MSA. Dystonia comes up again, so I mentioned a lot with corticobasal syndrome, where it can be one side of the body that's affected with cramping or dystonia, but we can see that most often in the neck with MSA, so marked flexion or anterocallus that is seen more commonly in MSA than something like Parkinson's disease. Brisk reflexes, again, part of the neurologic exam where we begin to see features that make us think that we're not dealing with Parkinson's disease itself, but perhaps a variant. So how do you find and persist in finding these diagnoses in these atypical Parkinsonian syndromes? Most often, again, because it's a gradual onset and slowly progressive disease, it takes some time before it's recognized by physicians. But most often it's primary care doctors that will begin the process first and then refer you on to a neurologist, generalist, subspecialist. Anyone who's from around here, again, the movement disorder docs in the Boston area, you might get to see sort of Dan Tarsi, one of the movement disorder folks at Beth Israel, or Lou Stodarsky at Mass General. Or, depending on the involvement of cognitive or behavioral symptoms, you might see someone like Brad Dickerson, so who specializes more on the memory disorder side of things. So it depends on where you come into the subspecialty group to then begin the process of refining the diagnosis. Initial evaluations will always include a detailed history, and I know that it's annoying when we ask you, but when did it start, and when did it change, and when did this happen? But it's really to try to get a timeline and how fast things are progressing, what's changing, and when it changed. That gives us a little bit more insight into what the diagnosis might be. As well as exposure to other medications. Again, our annoying questions of, well, when did you try that medication? How high did you go? What happened? What were the side effects? Gives us clues as to what else might be contributing, helps us rule out things like drug-induced Parkinsonism, for example, and other general medical problems are screened for as well, depression, thyroid dysfunction, those types of things that can contribute to a movement problem. And then we would often recommend imaging if it hasn't already been done. If it's already been done, we always appreciate when people bring their scans with them so we can take a look. Having the report from someone is often not as revealing because we like to look for specific things to evaluate these Parkinsonian disorders, and I'll tell you why. Sometimes it can be helpful in distinguishing among the atypical Parkinsonian diagnoses. When these features are present, it can be helpful. If they're not present, it doesn't mean that the diagnosis is excluded. So for example, looking just at the brainstem, that sagittal section that I showed you before, in Parkinson's disease, there's no focal asymmetry, no significant atrophy that we can see on imaging. With Parkinson's disease, you also have loss in the brainstem substantia nigra, but the amount of loss is so small that you don't see it on the MRI. In comparison, PSP, again, we have dropout of neurons in the brainstem, but what we see is narrowing in one part of the brainstem, up in the midbrain, that has been termed the hummingbird sign. So that peak, that beak in Parkinson's here has been compared to, say, a sparrow's beak. But because of the loss in the midbrain here, we see thinning that then will make us think of more of a hummingbird. So this is the hummingbird sign that we can look for. Again, if present, it can help us in addition to the clinical syndrome. If absent, it doesn't exclude the diagnosis. Now, MSA, we also have involvement of the brainstem, but we tend to have more involvement of this pons. The belly of the pons here is flatter when you compare it to PSP and PD. So again, the reason that we like to be able to look at the scans ourselves and in the office to see if we can pull out any of these features. Again, another example of the hummingbird sign in PSP. As an example, in Corticobasal syndrome, there have been some studies trying to pull out focal atrophy, again, the cortical atrophy that we might see. So this is an example of an MRI showing some mild atrophy in the cortex. But the interesting thing here is that they're doing a PET scan. So this is a way of looking for this particular scan and how the brain metabolizes glucose. So where is the brain not functioning well? Well, it's not functioning well on one side and in the correct area, the frontoparietal areas. So that can sometimes help us pull down and say, hey, this might be a corticobasal syndrome that we're dealing with. So this is where the imaging might help. Another example for MSA, so not just that flattening of the pons, but sometimes we'll look on a different set of images, so just a different section through the brain going this way instead of this way, called the hot cross bun sign, because you've lost fibers in the pons, and so you see these this little sort of white hash marks instead. So something that isn't there in folks with Parkinson's disease necessarily, but is sometimes there in folks with MSA. So this is the reason that we will recommend imaging and use that to help us in diagnosis. There are many studies now that are trying to refine these imaging techniques and develop new ones to more specifically identify and distinguish among these atypical Parkinsonian syndromes. So that is a huge area of research and interest to kind of push this forward, increase the specificity of our diagnoses, again, with the thought that it will help clinical trials and eventually help treatment. So again, we have more evidence to put someone in a particular diagnostic category that would then be perhaps responsive to medications coming down the pipeline. So these things are in evolution as well. During in the context of that clinical evaluation, most often at the end, depending on this history, the examination findings, the signs and symptoms that are seen on the neurologic examination, as well as any additional studies that have been done, one of two things can happen. One is that we can say we think that this is the most likely diagnosis at this time, it's Corticobasal syndrome or MSA, or we don't have enough information at this time, and we have to wait. Right? We wait for other symptoms to emerge, wait to see how people respond to certain drugs or treatment to know whether or not someone falls into a diagnostic category. And in the end, what I discuss with my patients is that it doesn't matter what we're calling it now because we're treating your symptoms now as best we can. And that might help us in the end determine a final diagnosis. But we are going to approach treatment the same regardless of what we're calling it now. It will be important in the future when we have these drugs that are targeting the specific proteins and the specific aggregation disorders. But right now we're doing a lot of treatments empirically based on the set of symptoms that a person is experiencing at that time. So what about treatment? There are no FDA-approved therapies for PSP, CBD, or MSA right now. And there are no gold standard clinical trials proving efficacy of any of the treatments necessary, so these large randomized multi-center trials. However, there are many potential treatments, and this is based on what we know from Parkinson's disease, from Alzheimer's disease, from other neurologic problems. We borrow a lot from experience in these other areas to then apply it to the treatment of these disorders as well. The other important thing to mention is that treatment has to be individualized because even if we are able to establish a most likely diagnosis, a most likely clinical diagnosis, PSP, CBD, or MSA, everyone is different. Everyone with PSP has a different spectrum of symptoms, things that are affecting their function to a different degree, how they respond to medications, how they tolerate medications. So everyone really has to be treated on an individual basis, and we always like to try to work together among physicians. So with the primary care doctors, the neurologists, endocrinologists, cardiologists, anyone else who might be involved in care, because we're all using medications, but with the goal of improving symptom and improving function as best as possible. So that coordination among physicians is crucial. So we'll mention first the medications used for Parkinson's to treat the motor symptoms of disease, levodopa, as Dr. Golby already mentioned. This can be tried in all the atypical Parkinsonian syndromes because we know that those structures, the basal ganglia and the input into the basal ganglia are affected, and it's dopamine driving those motor symptoms. So we will try it in these disorders. Some people do respond. Some people respond for a short period of time. Some people, there might be some mild improvement over months, if not years. We tend to push the dose much higher than we do in Parkinson's disease itself to get that response if necessary. However, it has to be balanced with the potential side effects coming from this drug, one of them being drop in blood pressure, which we mentioned in MSA is a big problem to begin with. So that has to be done cautiously. The other side effect to consider is hallucinations. People who have some of the cortical involvement, say with Corticobasal syndrome or other disorders, might be a little bit more prone to hallucinations with levodopa. So again, we approach it cautiously, and nausea being the most common side effect with levodopa. And in fact, that's where Sinemet gets its name. Carbidopa, as Dr. Golby mentioned, blocks the nausea from levodopa, and so it was called Sin without emesis, so without vomiting. Sinemet, carbidopa, levodopa. That's why it's always two drugs together. And we try other medications too. Now, the dopamine agonists might have more side effects than levodopa, so we use these cautiously, and they might not have as motor benefit as levodopa either. I tend not to use them so often, but some folks do respond and do tolerate these drugs. And again, it's a very individualized approach to whether or not this medication or this set of medications might be useful. Pramipexole and ropinirole are available. There's one other available now, hasn't been tried in the atypicals formally, but it's called retigatine or Nupro. Monoamine oxidase B inhibitors also used in the treatment of Parkinson's disease, but provide mild symptom improvement in those in Parkinson's disease itself, can be tried in the atypicals, not usually producing a significant motor improvement, but again, sometimes it's enough to help minimally. It's under study in multiple system atrophy as well as PSP. Those studies have not been conclusive, or the results haven't been fully reported. It was also looking at whether or not these drugs might be neuroprotective, and I'll talk about that in a minute as well. So might it slow down the disease? So there's other mechanisms being studied. Dr. Golby mentioned too amantadine. So not only in PSP, but we sometimes use this in multiple system atrophy. Again, some movement benefit. Some feel that there might also be some improvement in the ataxia, mild if tolerated, and if the doses it can be high enough. People have also said that they found some benefit with amantadine, not necessarily in movement, but almost in fatigue. And so sometimes when I try this drug in the atypical Parkinsonisms, it's not the effect that I want, but it's a benefit nonetheless, as long as it's tolerated. And amitriptyline, again, something that might be helpful with some of the movement issues in some of the atypicals, PSP, more than others. Medications for dystonia. So you heard me talk a lot about dystonia and corticobasal syndrome, also present in multiple system atrophy. Botox is the treatment that was designed to treat dystonia. It just happened that when people were treating dystonia that affect the eyes, called blepharospasm, the company found that wrinkles were treated, so that became their number one marketing tool after that. But Botox was made for dystonia, and it does help dystonia significantly. So if there are very focal areas that are involved, so not large parts of the limb, because your dose is limited by being the most potent neurotoxin known to man, so you can only use a certain amount. You can alleviate sometimes painful dystonia of the hand in corticobasal syndrome. Sometimes if there's dystonia in the face, it can help with that as well. So Botox is used in the atypical Parkinsonisms. Other medications that are used for dystonia can be tried include baclofen, Artane is also one of them, and some of the benzodiazepines, again, measured with some of the side effects, as all of these drugs will have side effects associated with them too. MSA. So as I mentioned, with the dysautonomia being such a problem, we do have medications that we use to help to manage and support the blood pressure. So these big drops, again, can lead to fainting spells, falls, and injuries. And as we add on Parkinson's medications, like levodopa, we drop the blood pressure even further. So we often use medications to elevate the blood pressure. Most often this is fludrocortisone or midodrine. And there's some others that are either investigational or others that can be used but have a different purpose. So pyridostigmine or mestinon is actually a drug for the treatment of myasthenia gravis. However, there's been some small studies to indicate that it might help support blood pressure, particularly that orthostatic hypotension that occurs in MSA and in Parkinson's disease itself. So we use these drugs to help support blood pressure in MSA. And then other non-medication treatments to help support blood pressure include ways of returning the venous supply back up to the heart, getting compression stockings used, sometimes abdominal binders to help improve that venous return. These are problematic. Compression stockings are really hard to get on, and if there's Parkinsonism involved, it's really hard to get on. So even just stiff socks or some variants or measures of compression stockings can be helpful. The other thing that we advise people to do is to elevate the head of the bed while sleeping, because it's that change in position that leads to the biggest drop in blood pressure. So if someone is sitting up, a little bit up during most of the night, then when they wake up in the morning or when they wake up in the middle of the night to go to the bathroom, it's not such a big change in that position. So it helps to support the blood pressure a bit as well. Other symptoms with MSA, so sometimes there can be those cerebellar problems, the trouble with coordination or ataxia, even in the limbs. And with some types of this form of tremor, we can use drugs or try drugs like baclofen, propranolol, amantadine, clonazepam. These are all sort of names getting tossed out there, but in a certain situation and a discussion with your physicians, you may consider trying one or more of these depending on benefit and depending on side effect tolerability. For the ataxia, there aren't really any good studies to show that there is benefit from these drugs, but some have been shown anecdotally to improve coordination and balance. Buspirone is an antidepressant. Gabapentin is actually a seizure medication, but helps everything except seizures. It helps pain, it helps restless legs, it helps tremor, it can help ataxia, it helps anxiety, but it's not a great seizure drug. We use it for lots of other things. But again, things to consider in discussion with your physicians. With the other autonomic nervous system problems in MSA, urinary incontinence, of course, is a big problem. And oftentimes, if there is urinary retention, that will require self-catheterization. Otherwise, some of the incontinence drugs may be tried. This is, again, most prominent in MSA, but true in the atypical Parkinsonian disorders as well, where incontinence is a feature. There are a number of agents that are used to treat incontinence. If I can, I often try to work with a urologist to be able to guide those treatments and guide which medications to try based on their assessments, which usually include some urodynamics and other testings to document where in the nervous system the problem might be. And if not, we try them empirically as well. Sometimes even desmopressin can be used at bedtime, and this is a way of blocking the usual circuits that trigger urination at night, so can sometimes at least fix the nighttime incontinence problem. And Botox, this is a Botox of the sphincters related to bladder control too. There's some studies that have documented improvement there for the treatment of incontinence. For the stridor, for the vocal cord problem, Botox comes up again in conjunction with ENT physicians. Oftentimes, Botox injections of the vocal cords can be beneficial. But sometimes if it's bad enough, people will consider undergoing a tracheostomy prophylactically so that there isn't closure of the vocal cords and disruption of the airway. Sleep apnea is also more common in MSA and probably related to the vocal cord dysfunction, so sometimes people will use CPAP to keep that airway open through the night as well. Myoclonus, again, I mentioned it mostly in the context of corticobasal syndrome, but can occur in the other atypical Parkinsonism. So there are a couple drugs that we use to control that muscle movement, that quick muscle movement, should that be a problem. Levetiracetam or Keppra being one that can help. That's also a seizure drug. It really helps seizures, but it also helps other features, myoclonus being one. Valproic acid, also a seizure drug, can help myoclonus. Medications for swallowing. So I mentioned this briefly because there is some anecdotal evidence that Prozac or fluoxetine might help with swallowing function. So if we need an antidepressant for depression and someone is having swallowing difficulties because of an atypical Parkinsonian syndrome, we sometimes consider using fluoxetine if it's the right thing for that person to get dual benefit, both in swallowing as well as management of depression and anxiety. And we use the whole host of antidepressants available too. I tend to use a lot of sertraline or Zoloft because I think that people tolerate it a bit better. All of them have side effects, and different people will have different thresholds for those side effects. Sertraline or Zoloft can help a little bit with some of the other manifestations, some of the irritability, the impulsivity, as Dr. Golby mentioned with PSP, that rocket sign of jumping out of the chair to go across the room to pick something up, right? It's that impulse to do it that you can't block. The filter is gone. Those circuits connecting the frontal lobes to the basal ganglia are not working well. So you lose that filter, you become impulsive. It's the same with eating. So you plate of food in front of you and you eat everything, right? And that's going to lead to swallowing problems. And it's that impulsivity that we will use the antidepressants to help control as well, in addition to the emotional lability. So again, we use medications that will hit multiple symptoms, allowing us to use just one drug to treat many different problems. And as Dr. Golby mentioned too, that we use in CBD and MSA, if there is significant cognitive dysfunction, we sometimes try these medications. There's no evidence that they help, but they're available on the market, and as long as they're tolerated, most often their side effects are GI side effects, so sometimes they're not tolerated, and they may be of benefit, we try them. Donepezil, rivastigmine, and galantamine, as well as memantine. Surgical treatments, so deep brain stimulation surgery is an excellent treatment in certain conditions. One of them being Parkinson's disease and a narrowly defined set of criteria for people with Parkinson's disease, dystonia, usually a genetic dystonia, and essential tremor. For these atypical Parkinsonisms, there's little evidence that it is of benefit, and in fact, there's evidence that there might be worsening of symptoms, so we really do not proceed with or recommend DBS for the atypical Parkinsonian syndromes at this time. Even with the pedunculopontine nucleus, there are some studies underway. The data that have been published so far have not revealed significant improvement, and in fact have had some significant side effects. And anytime we consider brain surgery, there's always that risk of permanent worsening neurologic deficit. The neurosurgeon that I work with in DBS always says, I can always make you worse. So we want to make sure that that benefit to risk ratio is really in favor of benefit before we jump into to brain surgery. So we tend to be very conservative in our approaches. And again, for the atypical Parkinsonisms, it is more risk than benefit. That ratio is not in favor of proceeding with brain surgery at this time in these disorders. And I know we'll talk about it more this afternoon, but I have to mention because it's a critical component of treatment, and that's what I tell all of my patients, that it's just like the medication that you take every day, exercise has to be a part of every day. And it has to be also tailored to the individual. What you enjoy, because we want you to do it every day, what is safe to do, right? So that you're not falling and injuring yourself or injuring a limb, which then impairs your mobility further, so then you lose ground. So it's really has to be an important part of every day. And again, those safety measures come along with close supervision from physical therapists, caregivers that can be trained with the physical therapist to make sure that it is safe. And again, every day, if not a couple of times a day, breaking it up into 10 or 15-minute stretches is a way to get it on board. And Janet already mentioned this, but CurePSP has a great information to provide to your own providers as well to help guide those therapies. Supplements, we already talked about the CoQ10. There are studies that are still underway in other disorders, including PSP and CBD, again at the Leahy Clinic here, not enrolling, but underway, as well as Huntington disease. I listed a whole bunch of medications, but even with those medications and trying to get symptoms better managed, we still don't have anything that, again, is FDA indicated for the treatment of the symptoms of these atypical Parkinsonian syndromes, and we need more treatments to better control these symptoms. So there are a lot of things that are underway. So clinical trials, very large studies designed to prove whether these drugs or any intervention are effective or at the very least safe and do not cause worsening of symptoms. So there's some that are underway in CBD and MSA. One in MSA is droxidopa and pyridostigmine, and this is looking at orthostatic hypotension. One way to keep up to date with this, I have it at the end, is clinicaltrials.gov, and they'll tell you different trials that are going on around the world to consider participation in, if it's safe, in other therapies that are under development. One recent trial was looking at IVIG, so intravenous immune globulin. This is a blood product, also done in multiple system atrophy. And this was a relatively small study, but this is the way these studies evolve. So it was a small study looking at IVIG and MSA. There was a hint of some improvement in the motor symptoms, so a more definitive, a larger study will be performed now to investigate this particular intervention. Now, is it something that we then use empirically? No, because this is a blood product. It's quite expensive, so out-of-pocket costs would be huge, and we don't know all of the safety data for these atypical Parkinsonisms, so it does have to be studied in a more rigorous fashion. As a converse to that, CoQ10 is something that's safe, so is it something that we can recommend people consider? Yes, we can say you can consider it without any proof that it would be of benefit. And so there are sort of different approaches to how we recommend people will pursue some of these treatments as well. Now, what we really want to do, we know that as over time the disease progresses, but what we really want to do is modify or slow the course of the disease. Something that has been termed disease modification, neuroprotection. How do we keep those cells in the brain healthier, longer, save them from what is happening and causing the trouble with the protein? Can we find interventions that slow or halt the disease? And there are a lot of strategies that are under study to really identify those underlying pathological processes and then target those processes, as Dr. Golby was mentioning, with the protein aggregation studies. There are a few large studies that have been done recently. One in Europe, the Neuroprotection and Natural History in Parkinson's plus syndromes. This was looking at a cohort of patients followed with PSP and MSA. And in the context of looking at overall disease progression, that natural history study, they did a study of a potential disease-modifying agent, riluzole. So this is a drug that's been around for a while now, is used sometimes in ALS. Unfortunately, with that study, there was no benefit found in slowing the disease in MSA and PSP. There was a recent study, we don't have the published results yet. This was also in multiple system atrophy looking at rifampicin. This was an anti-tubercular drug. But there was some evidence in animal models that would help to clear those synuclein aggregates in the cells of these animal models. So a large study was done in MSA. Again, unfortunately, that study did not show that it slowed down the disease. And as Dr. Golby mentioned too, we've had some tau drugs that have been studied recently. And unfortunately, there was no benefit when compared to placebo in slowing down the disease process. However, even though there's no evidence for slowing disease, these studies have been extraordinarily important because it has shown that these types of trials in rare diseases can be done, and they can be done well and safely. And so this has really set the stage for other drugs that are filling up the research pipeline now to come through and to get into studies faster and more efficiently. It has been extraordinary accomplishment despite the negative data. We've also learned a lot about disease progression during that time. These are data now that can be used to guide future clinical trials. Right, so if we're able to do sort of less of a placebo arm possibly because we already know the placebo arms from other studies. We know what disease progression would be. We might be able to get more drugs through faster in that way as well. And biomarker data. So as these studies have been done, we've also been able to capture biomarker data. You'll hear that a lot. What is a biomarker? Biomarker is a way of measuring a part of the process, a part of the pathologic process. And what it can do is it can shorten that time between knowing whether or not a drug delays or stops the disease. If you're able to change or modulate that biomarker, it shortens the study. The study becomes more efficient. So those studies have helped future clinical trials in that way as well. UCSF, Dr. Adam Boxer has been running a large neuroimaging initiative for some time now. He's collaborating with Dr. Dickerson here in Massachusetts at Mass General and also a site in Toronto. They are also the repository of a lot of the baseline data for Devunatide study and some other clinical trials within these disorders. So again, this is a way of best defining biomarkers of the disease and expediting clinical trials in the future. At UCLA, we've been working with another PET compound that I'll show you briefly as a way of identifying these protein aggregates in the brain. Can we do this in PSP? Can we do this in other neurodegenerative diseases? So that as we try these drugs that might break up these misfolded proteins, we then have a scan to be able to show whether or not these might be effective. So we're one site that is doing this, but there are a lot of places that are trying to develop these imaging markers to make sure that the drugs are hitting their target. And again, as mentioned by Janet early on, the ultimate diagnosis is pathologic. We learn a lot from those proteins. We also learn so much about the disease processes from brain donation. So participation in research through brain donation is also extraordinarily helpful as it contributes to the understanding of these diseases, and particularly as these treatments are tried and people participate in clinical trials as well. And for future therapies, so this applies to most neurodegenerative disorders. Success in one disorder, that's all we need, because it will be equivalent to success in others. We can apply this to other disorders. If we find one mechanism that's safe, and drug that's safe to help clear these aggregated proteins, it can then be tried in the other disorders. And that's the challenge, I think, with some of these atypical Parkinsonisms, particularly corticobasal. I told you about how much trouble we have in establishing a diagnosis. Well, in the end, if we find something that targets tau in PSP or the frontotemporal dementias, we can then begin using it in corticobasal syndrome as well, knowing at least that underlying pathology is there. So while there's particular challenges, a success in any one of those would be beneficial. And some of the approaches study not only the protein clearance, but cell energetics. So how can we boost the cell's ability to compensate generation of ATP, generation of that energy, prevention of free radical damage to the mitochondria, those parts of the cell that help to keep the cell healthy and fight what's going on. This is where the CoQ10 ideas have come from, as well as a side of neuroinflammation. So abnormal inflammation in the brain, there are targets that are being studied along that line of pathophysiology as well. Stem cell and gene therapy technologies are rapidly advancing, and I think will play a role in treatment in neurodegenerative disorders in general, the atypical Parkinsonisms included. There was a recent study in a multiple system atrophy using a particular type of stem cell, mesenchymal stem cells. But this is why I mentioned that while the technologies are advancing rapidly, they must be studied carefully. So this study suggested that there may be benefit in brain imaging, not in the clinical outcomes necessarily, not in the motor outcomes, but in brain imaging. But what they also found is that there was a significant increase in ischemic lesions. So it was causing small strokes in the brain. So this is what has to be balanced, right? And this is why these studies have to be done in a very cautious fashion, a very thorough fashion. It's not something that we can jump straight into. So overall, diagnosis is being refined by new criteria and greater recognition of the underlying pathology of these diseases. Current symptomatic treatments may provide some benefit, but really have to be individualized and working with all of your physicians together to try to find the right balance for you. And again, what's so encouraging is that the pace of research has really recently accelerated. And this is at the genetic level, what we know about the pathology and other proteins that are being identified as being causative for these disorders. The results from these large multi-center clinical trials, again, negative, but ways they have shown that these can be done and other things can move through the pipeline. And so we really have to keep up this momentum. I think we're in a great place right now and seeing major progress being made in the future. So thank you. Thank you to everyone who has participated in a research study in the past, or if you're going to participate one in the future, for being a part of this meeting, for what you do for your loved ones, for your family, for people suffering with these disorders, for your community, if you're support group leaders, if you are medical professionals that are helping with these disorders. And thank you very much to CurePSP for holding events like this. Thank you.